The most common sleeping pill in the world raises your dementia risk by 50%. You don't even need a prescription for it. You may have tried it. A lot of people take it every night, and it doesn't get enough attention. In this video, I'm going to give you 4 sleeping pills I wouldn't take. I'll explain why, how to stop them safely if you're already taking them, and what actually works for sleep instead. And if you're thinking, this is probably an issue for older people, I'm afraid not. It's a greater issue for people in middle age. More on that shortly. I'm Dr. Rowan Colgan. Medical school didn't teach me any of this, so I do my own investigating. Let's get into it. Let me show you the evidence from 3 of the biggest studies in the field. The first is from the US, published in JAMA Internal Medicine in 2015. Long-term daily use of this drug class, 54% higher dementia risk. Then an even bigger study from the UK, also JAMA Internal Medicine 2019, the biggest study of its kind, 49% higher risk in the heaviest long-term users. And when researchers pulled 26 different studies tracking over 600,000 people, the conclusion was identical, a 50% higher risk for long-term users. So the picture is consistent across the studies. So what does this mean for you? Well, a 50% higher relative risk doesn't mean you'll get dementia. It means that for every 100 people taking these sleeping tablets long-term, roughly 10 to 15 more people will develop dementia than would have otherwise, depending on their starting risk. Now, you may or may not be one of those, hence some will comment that they've been in them for years and are fine, but do you want to take that chance? This is one of the largest modifiable risk factors for dementia we know about. So what's actually going on in the brain? In your brain, there's a chemical messenger called acetylcholine, and your brain cells use it to talk to each other. So it's essential for memory, attention, learning, and more. And in Alzheimer's disease, acetylcholine activity is low. That's one of the most consistent findings in dementia research. And the drugs doctors prescribe for Alzheimer's, donepezil, rivastigmine, galantamine, all work the same way. They raise acetylcholine. That's the treatment. Now, the 4 sleeping pills we're talking about today have one common mechanism. They block acetylcholine, and for this reason they are called anticholinergic drugs. This is the effect doctors worry about. Take them occasionally, your brain handles it, no problem, but take them every night for years, and you're creating a chronic low acetylcholine state in the brain, identical to one of the early features of Alzheimer's. And over time, this causes the acetyl-producing brain cells to atrophy or wither from chronic underuse. Your body thinks it doesn't need them. And this leads to measurable shrinkage in the brain, seen on MRI, including in the memory regions, particularly the hippocampus. So the issue is with long-term use, which is one of the key points of this entire video. So before I name the 4 pills, this is worth emphasizing. Sleeping pills in general are designed for short-term use only, usually no more than 2 to 4 weeks, to support you through a temporary life event. Every sleep specialist and official medical guidance is clear on this. They are not for long-term use. These drugs sedate you. They don't fix underlying sleep problems. They give you fragmented, lower quality sleep that skips the deep stages your brain needs to consolidate memory and clear waste. And they bring other risks, even before we talk about dementia. Morning grogginess, falls, a major cause of hospital admission in older adults, dependence, rebound insomnia when you stop. So the dementia risk is simply the most serious consequence of long-term use of drugs that were never meant for long-term use. The problem is millions of people are using them every night and for years. And there are much better solutions for longer-term sleep issues, and I'm coming to those shortly. But if you wish to take sleeping tablets long-term, and I recommend you don't, these are the 4 I would definitely avoid. The first is diphenhydramine. In the UK, that's Nitol. In the US, it's Benadryl PM, Z-Quil, Unisom sleep gels. The second is promethazine. In the UK, Sominex, Phenergan, Night Nurse. In the US, mostly on prescription. The third is doxylamine, the active ingredient in US Unisom sleep tablets, less common in the UK. And the fourth is amitriptyline. This is a prescription-only drug given off-label for sleep. Low dose, 10 to 25 milligrams, one of the most commonly prescribed medications in UK general practice, millions of prescriptions every year. Now, a quick clinical distinction on amitriptyline: if your doctor prescribed it for chronic pain or nerve pain, that's a different conversation, and it is still recommended for those conditions. But bring it up at your next doctor's appointment. Don't stop on the back of a YouTube video. And a quick word on the other sleeping drugs people will ask about: the Z drugs, zopiclone and zolpidem, and the benzodiazepines, diazepam, temazepam, and lorazepam. These are separate classes of sleep aids. They work differently. They don't block acetylcholine. There is a dementia risk, but it appears to be weaker, and they bring their own serious problems: dependence, falls, and withdrawal that needs medical supervision. So, same principle, not for long-term use, and I'll come back to how to stop these safely in a moment. But first, the one finding that really surprised me. Everyone assumes the dementia risk from these drugs is something to worry about when you're older. The headlines have mostly framed it that way, and official medical guidelines typically flags these drugs as use with caution in older adults. In almost every medical condition, the presumption is you can handle things better when you're younger. But in late 2025, two big studies from Sweden and the UK found the opposite of what everyone presumed. The dementia signal was stronger in middle-aged people than in the elderly. So if you're in your 40s or 50s and you've been telling yourself this is a worry for later, unfortunately not. Middle age is probably when this matters most. So if you currently rely on one of these anticholinergic sleeping aids and you're keen to stop on the back of this video, what should you do? Well, there are two things you need to do. First, you need a plan for managing your sleep, which I'll give you in the next section, and you need to stop the medication safely. I'd recommend you discuss this with your doctor first, but here's a summary of what you need to know. The over-the-counter anticholinergic sleeping aids, Nitol, Benadryl, Z-Quil, and the rest, you can stop tonight. You can expect a week of worse sleep, but it will settle. That's not the underlying problem coming back. That's simply your brain rebalancing. Amitriptyline, the Z drugs, and benzodiazepines all need to be weaned slowly with guidance from your doctor. Don't stop them suddenly. Most importantly for benzodiazepines, when sudden withdrawal can cause seizures. And if you're not sure which category your medication is in, ask your doctor or pharmacist, or you can do a quick Google search. Okay, you've made the decision to quit, which is great. So what do you do next? What actually fixes long-term sleep issues? Well, that's a whole video in itself, which I plan to do soon, but for now, I'm going to give you the three things that matter most. First is sleep regularity. This is even more important than how much sleep you get. What this means is waking up at roughly the same time every day, including weekends, and by default going to bed at roughly the same time each night. A 2024 UK Biobank study of 88,000 people found that the most irregular sleepers had a 53% higher dementia risk than regular sleepers. This single thing is arguably the best thing you can do for good sleep and recommended by every sleep expert. Second is manage your stress. I interviewed one of the world's leading sleep experts recently who put it perfectly. Most people don't have a sleep problem, they have a stress problem. Racing thoughts at 2 a.m. are nearly always a stress issue, not a sleep issue. Think about it, we've all experienced this temporarily, a death in the family or spells of stress at work, and our sleep tends to be disrupted too. It's very hard to sleep when we have these daytime worries that spill over into the nighttime. But for many of us, we live in states of chronic low-level stress that leads to chronically poor sleep. Now, practical things that genuinely work: a structured worry time earlier in the day where you write down what's on your mind, including actions to solve those worries. This is something I hugely recommend, and we'll do a video on this soon. Putting the day to rest is a method to separate the busy daytime from the quieter nighttime. And a proper wind-down routine in the hour before bed: limit screens, no work emails, no scrolling. Just actions that are relaxing and calming and prepare you for sleep. And if you want more information on any of those, leave me a comment. Third, if you have a genuine chronic insomnia, so you've tried everything else, still lying awake with a racing mind for weeks or months at a time, that's when you reach for cognitive behavioral therapy for insomnia, or CBTI. This is the gold standard treatment for insomnia, recommended by all of the leading sleep organizations and world experts. It outperforms medication in head-to-head trials, and the effects last long after the treatment ends, unlike drugs which only work while you're taking them. Now, it comes in various forms: digital programs, apps, or books. I even have my own online course if you're interested, link in the description. And one more thing, if you genuinely feel you need a drug while you're building these new habits, a decent option is melatonin. Melatonin has the cleanest profile of any sleep drug, no anticholinergic effect, no dementia signal in the research so far, no taper needed when you stop. It appears to have a modest effect, but without the risks the others do. It's a useful bridge while you work on the real fix. Now, the strongest counter-argument to this whole story is this. Some critics have said that maybe people who develop dementia just had worse sleep first, and that's why they were taking sleeping pills. So the pills aren't causing the dementia. Early dementia is causing people to use the pills. Now, it's a good argument, but the researchers tested it in a big UK study from 2019. They looked at people who had been taking these drugs as far back as 20 years before they developed any signs of dementia, long before any early dementia symptoms could have driven the pill use, and the risk remained. And the more pills they'd taken, the higher the risk. It would certainly seem clear that the dementia risk is real. So the pill you thought was harmless and doing you good by supposedly helping you to sleep is almost certainly not, if used long term. If you take one of the over-the-counter ones, stop tonight, a few nights of worse sleep, then it should settle. If you're on a prescription one, see your doctor first. Do not stop suddenly. And in their place, go to bed and get up at the same time each day, manage your stress, ask about melatonin if you need a bridge. And if that's not enough, you should consider CBTI, and you can get 10% off my online CBTI course, which you can start today using the coupon YT10. Just click on the link in the pinned comment or description below. If you enjoyed this video, you can check out more via the links on screen now, and click subscribe for all my future videos on health and wellness topics. Thanks for watching. Until next time, take care.